Good evening, respected professor and dear my dear students. I welcome you all to this new session of Raisa DNB online on Osce. Today, professor will be presenting on Osce pattern questions for exam going students. Over to professor.
Thank you. It's a small correction. It is not only for exam going students, those who are joining new also some questions will be there. So it will interest both students awaiting practical exams as well as those who have joined and on the way to learn this specialty. Now I have prepared two Osce patterns. Last COVID time, because they could not give you the real physical patients to conduct the exams, like they resorted to online examinations. They gave, even for the long case and short case, they gave case scenarios and then gave some 25 hostel questions. And then they conducted the exam. What exactly was the pattern is shown in one of the Osce's I'm going to present to you. So it is more or less like a mock examination for you. Those who are going to appear for exam, you can test your strength of knowledge, how much you have learned. Because today I have not given you any topic, and by seeing these questions, you have to answer whatever you have learned all these years. So it is more or less like a mock exam that you are going to appear for. Once you have enabled screen sharing, available? Yes. Are you all able to see the screen? Today it will be more like an interactive session, so students also have to unmute and they can answer. So this was the pattern that was kept for the last 2-3 batches during COVID time. So the previous pattern for DNP practical exam for this year, that is last year, to be completed in a single day having 3 components. To minimize travel by candidates and reduce interstate travel, National Board of Examination has increased the number of centers. So most of the students luckily had centers in their own cities without the need for traveling. And the Osce component, there were 25 stations of 6 marks each for 4 minutes duration, totaling 150. And there was Viva component of 4 into 10, 40 marks. Clinical case examination component 35 into 270 marks, ward rounds 40 marks, and total practical 50 marks. So the passing criteria for candidate was candidate must obtain minimum 150 out of 300 marks in aggregate out of the 2 components of the exam, that is Osce and practical Viva and clinical, to pass the DNB final. So Osce was considered as a major component, Viva and clinical put together as another component. So combined together, you are supposed to secure at least 150. And getting this Osce component marks are quite easy because they are all like pictorial descriptions with questions side by side. So if you prepare well for the Osce, you can easily get the marks required. So make it in the full screen. So this is the pattern that was there. Now we are going to see the questions that have been prepared. This is the case scenario, first case scenario. A 25-year-old trainee at 28 weeks of pregnancy complains of severe right iliac fossa pain with nausea and vomiting, diagnosed to have a twisted ovarian cyst. We have been planned for a laparoscopic excision of the twisted ovarian cyst. So what are the challenges in the anesthetic management of this question? So even though it is given as a long case, it is all to be completed in a short time. So you have to know what are the basic things that you have to manage in this case. So to make it an interactive session, and the senior students who are going to appear for exam. Can anyone take up the case and then describe what are the challenges that you are going to face? Pratik Shukla, we'll start with Pratik. Are you there, Pratik Shukla?
Good evening, sir.
Good evening.
Sir, it's a 25-year-old primary patient, 28 weeks
Yes.
pregnancy.
Yes.
So,
Very good.
twisted ovarian cyst. Sir, so this case, in this case, pregnancy would complicate the normal elective cases. So, I would suspect that patient would be anemic. She is a primary, and we have planned for laparoscopic excision. So complication arising due to laparoscopy means pneumoperitoneum creation will be a second challenge for anesthetist. So, sir, hemodilution will also be there. So fluid overload we cannot means we'll have to assess the volume of fluid which you are giving to the patient. Cannot use much of opioids, that will cause fetal depression, sir.
First of all, having read the case scenario, under what category of this surgery will happen? How will you title this case scenario?
So this is an emergency surgery, sir, with the ASA grade.
Non-obstetric surgery in a pregnant patient. Okay, there are obstetric indications and non-obstetric indications. So this is a non-obstetric surgery in a pregnant patient, isn't it?
Yes, sir.
So it is nothing to do with the uterus or the fetus. It is associated with of course, the adnexal ovary is also part of the gestational thing, but it is a non-obstetric surgery. It has nothing to do with the delivery of the baby or saving the baby, but it is another complication which can cause problem to the patient. So how do you approach this? Arun, are you there? Arun from Railways or Mobile? Exam points. Or anybody who is exam going who want to answer, they can answer. Just make an attempt. If there is nothing harm in trying to say what you know. This is how you are going to be prepared for your exam. You do not know what question you are going to face, and you have to collect your thoughts and then present the answers, isn't it? So this is a mock trial, mock practice for you. Any student from Anamle, Pavitra? I saw some names there. Nobody wants to take up the challenges. Any of the railway pages who are there? Say at least we are here or no. Queen, are you there?
Dr. Amu?
Who is a post-DA student or a primary
Dr.
student?
Amu is there, sir. Dr. Amu
We
can
have a
answer.
call over in ICU, sir. We are called over in ICU. We are on duty today.
Okay. So you are all. Anyone else? I saw about 12 candidates' name. Anybody who is willing to answer this? Okay, first question I will go through the answers. Let us see. So this patient is at the third trimester of pregnancy. So there is no fear of teratogenicity, isn't it? Pratika, do you agree with me?
Sir. Yes, sir. Definitely, sir.
She is there, third trimester of pregnancy. So the organogenesis is all completed. So there is no fear of undergoing anesthesia, and there's no fear of teratogenicity. But the other two problems are she can go for premature labor, resulting in the birth of a premature baby. Because this anesthesia and stress of surgeries in the third trimester, even though she has not completed her full term, there is always a possibility that she can go for premature labor, which can result in a baby born at 28 weeks, which will be quite premature. Okay? So that is the second challenge. So she needs a thorough evaluation to assess her general health. welfare of the fetus and rule out any pregnancy-induced complications like gestational diabetes, gestational hypertension, kidney diseases, preeclampsia, or any other occult valvular lesions like hidden metal stenosis. So examine and make a thorough preoperative evaluation of the patient for her overall well-being and associated complications. Rule out any associated complications. Okay, so this is the second problem that we are looking at. So all regular investigations to be carried out and airway evaluation is to be done because in pregnant patient we always expect some amount of airway difficulty. So make a thorough airway evaluation. And problems can be classified into two categories. One is all problems associated with pregnancy and those associated with lap surgery. So at this stage, can you just tell me what are the problems associated with pregnancy? We have already mentioned what are the two problems. So what will be your plan for the problems associated with pregnancy? Anyone can answer. Learn to open your mouth and answer. This is the training for you to answer in the exam. Don't feel shy. Something's interested. Pregnancy related, we have to give position. Left lateral tilt is very important to prevent diaphragmatic compression. There is always the aspiration prophylaxis. Pre-oxygenation is a must. Then CV stability for both fetal and maternal safety. And you must think of using tocolytics to prevent premature labor and premature birth of baby. And you have to monitor the fetal welfare intraoperatively. And she will be in a hypercoagulable state. Pregnancy is always a hypercoagulable state with the chances of thrombus formation. Don't you think you know all these problems? Pratik? Hello, answer yes or not, yes, to make
Yes, sir.
something
Yes, sir.
interesting.
Hello. Yes, sir. Yes, sir. Yes, sir.
So this is how you have to recollect all these things, you know. But don't forget to give the left lateral tilt. Think
Yes,
of
sir.
aspiration prophylaxis. Think of, see, now all these days you have all been given the topic, you have nicely read at home and then prepared and then come and vomited whatever you have done. This is a training for you to immediately think what you have learned all these days and try to recall them and present it. That is the training that I am trying to give. Okay. So these
Yes,
are common problems related to pregnancy. And here the additional problem is the premature labor and birth. What are the prophylactics you can think of? Please tell me that answer.
Sir, isoxaprine, salbutamol.
Salbutamol, beta-2 agonists. So you can give it at the inhalation route, isn't it? So think
Yes.
of that. And how can you monitor the fetal well-being intraoperatively?
So fetal Doppler means assessment.
Right. So can you use a tococardiograph?
Yes, sir. We can place a tococardiograph.
Laparoscopic surgery. Imagine that is a problem here. So placement, yeah, you can place, but in a different location. But area away from the port they are going to put. Okay. So there are 7 problems I have mentioned. One is the position, aspiration, prophylaxis, pre-oxygenation to be done correctly, and you must maintain CV stability and use prophylactic tocolytics, monitor the intraoperative heart rate and well-being, and prevent any chances formation. Now the other problem is the lap surgery related. So there will be alteration in CVS, RS, and renal physiology due to pneumoperitoneum or carboperitoneum that you are going to create, and carbon dioxide absorption affecting fetal oxygenation. So that is you have to keep in mind and adjust the flow and pressures. And raised abdominal pressure can compress the uterus. So again, that pressure also has to be monitored carefully. Don't you think these are all very easy to answer? Probably you have all got little tense
Yes.
because of the new way of questioning. Okay, so
Yes.
let us forget that. How, this is how you have to plan your answer and make a presentation. Okay. So now
Yes.
this is the long case I have just given for an example. There is another paper where you will have some more cases. So I am just going to show some slides here. Can you identify this instrument? Have you ever seen one like this? Take your time to observe the picture correctly. Try to answer. What does it look like?
Silicone mask, sort of.
It's a face mask. It's a face
Face
mask,
mask.
isn't it? Okay. Now, what other things you find in that? See, you have something like a strap, then you have something, a corrugated attachment here, then there is another attachment opening here. Maybe most of you would not have seen this, but this is, I can give you a clue that it is a resuscitation equipment. This is a mouth to mask ventilation port for oxygen device. Okay, so you can give oxygen along with a mouth mask. Instead of putting your mouth onto the patient's face, you can hold the mask here and then blow through this and give supplemental oxygen through this port. Okay, so it is called a mouth to mask ventilation support device, oxygenation device. So what are the steps in the using this? Imagine there is a patient who is apneic and unconscious. And you want to give a mouth-to-mouth breathing to that patient. That a cardiac arrest. Just imagine how will you use this. This is a simple mask. Imagine how will you use an ambu bag if it is there. Ambu is not there, but this mask is there, and your lungs are going to be the ambu for the patient. So how will you use this? In the resuscitation of any unconscious apneic patient, what are all the steps?
So first of all, sir, putting the mask in the means position around the nose and the mouth of the patient, and adequate sealing of the mask. Then before that, ensuring that nothing is obstructed in the mouth, means
Very good.
there is no tongue fall and other things. Then, sir, with adequate seal and adequate extension of the neck, so slight jaw thrust can be given, and along with that, sir, we can blow the air through the port which has given in the mask.
The top. This is the for opening for blowing the expired air. This is the oxygen. So normally, when you use this sort of equipment, you will be giving only your expired air. But in order to give more oxygen, also this mask has been designed in such a way that you can have an oxygen. If you have an oxygen source, you can give additional oxygen, and you can push that oxygen by your expired air ventilation. Okay, so that is all the advancement that has been done with the mask. So first thing you do is connect the oxygen line to 10 to 15 liters flow through this adapter of the attachment. Okay. Then the second thing is establish airway. This is what you normally do in any unconscious patient. Head lift, head tilt, chin lift, and jaw thrust. These are the three steps of triple maneuver, it is always called. Head tilt, chin lift, jaw thrust. But what is the precaution you should take when you do the head tilt? In an unconscious patient, an apneic patient, when you do the head tilt to clear the airway or establish a good oropharyngeal airway, what should you take care of?
Sir, known
Cervical spine injury.
Cervical spine injury, excellent. You should make sure that there is no cervical spine injury. Don't do a violent head tilt or a chin lift is okay, but head tilt you should be very, very careful. Always rule out the possibility of a cervical spine injury, and then do this. And you can achieve this with the jaw thrust also by if you don't have a oropharyngeal airway. Okay. Then establish seal with mask. What you said, Pratik Shukla, is very correct. Ventilate mouth to mask. So these are the three steps rather. Connect oxygen flow with the not given here. Establish clear airway by adequate chin lift and with possible insertion of oral orofacial airway. One more thing you can add is if there are any secretions, clear all the secretions before you start blowing. So establish a good seal with the mask, ventilate mouth to mask. Okay. Now, what are the indications, contraindications, and complications of this method? Supposing you have this equipment and you want to resuscitate a patient, what are the indications? Already I have told you what is the indication where you will use it. So that is the answer already you know. What are the indications? Whatever I have told earlier, you have to repeat. That's all. Why there is so much of hesitation?
So
See,
apneic
patients who are unresponsive, apneic, or have depressed respirations. For those patients only you are going to do the resuscitation, isn't it? So patients who are unresponsive, who are apneic, or have depressed respirations. Contraindications, none when the above conditions apply. Okay, there is no contraindication for doing this sort of resuscitation when these patients are like this. But what is the complication you can produce if you don't use the equipment correctly and keep the airway properly? In any mask ventilation, what is the common complication? Even
So
during your
gas can go into the abdomen and it may lead to aspiration and
not abdomen, gastric distension, which
gastric distension.
which you come across every day. If you don't do a proper pre-oxygenation with mask ventilation, especially in pediatric patients, you can see there will be a big bulge in the gastric region, isn't it? So the most important complication is gastric distension. So you should not keep the airway flexed or anything like that and blow very hard. Then all the air will go only into the stomach instead of the lung. So that is the most important complication. But don't you think it is very common things which you have known, have done? These things are only asked in the question form. And that pattern you have to write these answers. You are not going to answer orally. So they will show this picture for about 4 minutes and you have to write out the answers A, B, C, D and then fill the paper. That is how it was conducted. Okay. So, but in the exam, if they go for the live exams this time, you may be asked all these things to orally answer. Okay. So both ways you will be benefited if you keep answering these questions. All of you have seen this in your practical practice in the theater.
Hydroxyethyl.
So our name is written, hydroxyethyl starch, hetastarch or OUN. What are the properties of this fluid? Are the properties, is it a crystalloid or a colloid?
colloid, sir.
Yeah, why so much of hesitation? This is a basic fluid, all of you would have used in your theater. Okay? Right? It's a colloid. Then this is a colloid fluid for intravenous administration. Correct? Right. Okay. What other properties you have? How do you describe hydroxyethyl starch? See, there are some numbers given here. H-star 450, H-star 6%. So how will you describe this particular colloid? What are all the properties or descriptions you have to attribute to this particular colloid? When you use Maxil or Dextran, no, they are all colloid with a single property. But this hetastarch or hestril has got a 3 different properties incorporated in that. What are they?
So it is a
What is this
non-ionic. It is a non-ionic volume expander used in intravenous therapy, sir.
Ionic volume expander. But what are these things? What is this 6%? What is this 450? What are those things represent? It is a starch obtained by the process of
So,
right. Am I audible?
yes, sir. Yes, sir. Audible,
Right.
sir.
Okay.
Audible, sir.
So it comes in two different concentrations. One is 6%, another is 10%. Okay. Earlier they were producing it in 6%, 10%. Now they have made it 6%. So the characteristic of metastarch are identified by three numbers. For example, it may be 10%, 200, and 0.5. The first number denotes the concentration, either it can be 10% or 6%, which means just like your 1% xylacane, 2% xylacane, which is 20 milligram per ml, it is 2%. 10% is 100 milligram per ml. 6% is 60 milligram per ml. So this is the concentration of the drug. Then the second is the molecular weight. This 200, 450, they are all the molecular weight of the substance. And 0.5 is what is called the molar substitution. So it has undergone improvement through 3 generations by reducing the concentration. Earlier it was first introduced as 10% in a very enthusiastic way to improve the intravascular volume by osmotic absorption from the interstitial fluids. But later they found it is causing a lot of damage to the kidneys. So they reduced it to 6%. And the molar substitution is another important advancement. It makes this drug more safer compared to the older ones. So they are not preferred now, commonly now. The initial enthusiasm, it has now become less preferred drug because of the toxicity, complications like pruritus, nephrotoxicity, and hepatotoxicity. So how to understand this molar substitution? So these are the properties of this testril or hetastarch or olivine, whatever you want to call it. Concentrations available are 6 and 10%. So it determines the initial volume effect. 6% is iso-oncotic with a volume effect of 100%, whereas 10% is hyper-oncotic with a volume effect of 145%. So now 10% is no more available. 6% is iso-oncotic, so it is being used now. Around what is the difference between iso-oncotic and osmotic? Osmolality and oncotic pressure, are they both same or different? Anybody can answer for that? What is the difference between oncotic pressure and osmotic pressure or osmolality? Right, so average molecular weight, there is a low molecular weight 70 kilodaltons, medium 200 or high 450. What you saw in the earlier picture was a 450 kilodalton molecular weight. Determines the intravascular persistence, the duration and extent of tissue storage, side effects such as itching, anaphylaxis, blood coagulation, especially on effects on factor A and von Willebrand factor and renal functions. Then the molar substitution is where they are all having carbon atoms, 6 positions, and where they are substituted, that is CC2 to C6 ratio determines water solubility and molecular weight. So determine the rates of S degeneration by serum alpha amylase. Higher the C2 C6 ratio of more than 8, more slowly degraded. So they stay in the vascular compartment for a very long time. Initial preparation stayed up to even 48 hours within the circulation without getting excreted. So that is why now they have reduced all the molecular weight, the concentration, and altered the C2C6 substitution to eliminate it at least within 10 to 24 hours. So the solvents that are Gellam used, they don't come alone. They are usually combined with normal saline or vinegar lactate. They are called balanced hydroxyethyl starch preparations. Overall, less negative effects on homeostasis and platelet aggregation when you use a saline preparation. So all the colloids, they interfere with coagulation. Hemaxil interferes with both the blood grouping as well as coagulation. Dextrans are actually used as an anticoagulant for microvascular surgeries to prevent capillary thrombosis. And the source from which they are made they can be either potato derived or waxy maize derived, and they exhibit a faster clearance from the population and low average degree of blanching. So this is how the structure will be looking like for this thing. And this is where the substitution has to be done. This is the C2 position, this is C6 position. Okay. So this is where the substitution, and that ratio only determines the water solubility and molecular weight. Now the molar substitution ratio is 0.7. It is called hetastarch. There is the substitution of 0.6. It is called hexa, 5 penta and 4 tetra. So the names that are given are based on the molar substitution. That another point that you have to know in the answer in the examination. So hetastarch, because the molar substitution is 0.7, it is a high molecular weight. The trade names are Hespan, plasma sterile, hexend. Whereas hexastarch is a high medium molecular weight hydroxyethyl starch, it comes as yellows. 0.5 is pentastarch, which comes as sterile, pentaspan, and humulose. And 0.4 is tetrastarch, low molecular weight, volumen, vinofundin, tetraspan. All these things are plasma volume ready bag. All these things are the trade names for that. And based on these improvements, they are called first generation, second generation, and third generation, and advanced third generation. Okay, so all these things come in various names like this, and these are the points that I thought will be useful. That point of view. Now, how do you use a laryngeal mask airway? This is a question that you can get for seniors, the juniors also, maybe who are having do you have any experience in usage of laryngeal mask airway? What are all the performance steps of laryngeal mask airway? How do you use a laryngeal mask airway? What is its role in airway maintenance? Even in difficult airway algorithm, nowadays we use laryngeal mask airway. So how will you prepare and assemble the necessary equipment for laryngeal mask airway insertion? So it fits an appropriate. First thing, it must choose the correct size LMA. That is the most important thing in using LMA. So how do you decide how to use the LMA? How do you pick up the correct size? What is the criteria? Is it the age or height or weight?
Sir, according to the weight, we select the size of the LMA, sir.
So patient's body weight is the main important thing, isn't it? Very
Yes,
good.
sir.
Okay. Then how do you test for the integrity of the cuff?
Sir, we inflate the cuff and we just look whether there is any leak or not.
Yes.
While
You inflate and leave it there for some time, see whether it is shrinking or shriveling or maintaining the size as you inflated, and then will you use it inflated or deflated?
Sir, I will deflate it. Then means the semi-inflated means not too much deflated, not fully inflated.
Fully inflated. That is all. Okay. So deflate cuff on a flat surface and lubricate LMA on the posterior surface. Why you should not lubricate on the laryngeal side?
Sir, it will slip from its place when we position it due to lubrication if done on the anterior side, sir.
Not that. See, why if you duplicate only on the posterior side and not on the laryngeal side or the ventral side? Why? Posterior side will help you to slip it nicely into that. But if you lubricate, especially with the local anesthetic on the laryngeal side, that is the upper chest side, what will happen? Will it, surface application, will it cause numbing of that or obstruct the reflexes?
Yes, sir. Post
Can be an additional danger for aspiration.
op, yes, sir. Yes, sir.
So that's why you are supposed to. Then you have to open the mouth using crossed fingers technique by performing a tongue jaw lift. Do not hyperextend the neck, clear the airway if needed. This is all the preparation that you have to make before. Then insert the tube into the mouth and place it so that the curvature is the same that of pharynx, directing it posteriorly until resistance is felt. So this is what we normally do. Then inflate the cup with the appropriate amount of air. How do you decide the amount of air? Corresponding to the size of the tube. And remove syringe. Earlier there were guidance value given along with the by the manufacturer. How much air you should inflate in what according to the size of the tube. Is it now followed the same way, or we are now changing the guidelines? Previously, if it is a one size tube, it is supposed to be 10 ml. With 1.5, 15 ml. Two size tube, 20 ml. So 10 ml for each increase in size. 4 size, 40 ml, 5 size, 50 ml. Was like that. It was the guidelines that were given by the manufacturers themselves. But now that has been repelled and now it is changed. Why? The idea? What will happen if you inflate with a 50 ml of air and leave it there for about 3 hours surgery or 2 hours surgery?
Mucosal necrosis.
Necrosis, it also severe sore throat, mucosal damage, okay. So,
Yes,
a lot of post extubation complications are seen in these patients with this high volume of air. So, now the recommendation is whatever size you use, you have to just keep inflating until your reservoir bag becomes adequately filled. Then you squeeze the bag and listen for any leak sound. There is no leak, just leave it at that. Then again, after squeezing, the reservoir bag should immediately fill up nicely. So these are the 3 points that you have to look for. One is, as you inflate the air, watch for the appropriate distension of the reservoir bag. Stop inflating air into the cup at the time. Squeeze the bag. Listen for any leak sound. If there is no leak sound and the bag immediately refills nicely, then that is the appropriate volume. So it doesn't need to be filled up like 10 ml or 20 ml. You can, even it may be 5 ml, it may be 7 ml, it may be 8 ml, or maybe 15 ml. But maximum should not exceed 10 ml per size. Okay, that is the guideline that you have. So inflate, squeeze, listen for leak, bag refilling, then your filling is right. So earlier we were using bite block also. Do the current generation LMS require any bite block?
No, sir. They come with a.
They come with a bite block. So
Okay.
that is what is the improvement. That is why we call it them as first generation, second generation, and third generation, because earlier it was not there. Patient can bite the tube and occlude it, especially LMA Classic, originally introduced by who is the inventor of the LMA?
Brain.
Archie
Bean.
Jeffrey Payne. Yes, very good. So that first prototype was never had a bite block. So later on, because of this problem, the patients can rise the tube, they introduce the bite block in the later generations. Then produce noticeable chest rise and auscultate breath sounds, confirm correct position of LMA by calorimetric EPCO2 capnograph. What do you understand by this calorimetric EPCO2 capnograph? How does it work?
Sir, if carbon dioxide is present in the expired gas, change in the color of the means color change will be appreciated, sir.
What changes color? What is the chemical that
Sir,
changes?
acid means
It's
carbon
litmus paper.
litmus paper test.
What you have studied in your basic school chemistry, litmus papers. They're getting converted from acid to alkali and alkali to acid. So that litmus paper has been incorporated in this calorimetric EPC photograph. So the carbon dioxide that comes out in the expired air gets converted to carbonic acid, and that acid will change the alkali into acid. So there will be a color change. Okay, so that is how it is working. Then once you confirm the position, secure the LMA in place, perform correct ventilation, respiratory rate for respiratory arrest with 1 breath for every 5 to 6 seconds. And for cardiac arrest, 1 breath for every 6 to 8 seconds. So you can use LMA for both respiratory arrest as well as for cardiac arrest. If it is cardiac arrest, you give lesser number of breaths because you want time for cardiac compression also. Whereas if it is only a respiratory arrest and the heart is still beating, you go for a little higher number of breaths. And deliver each ventilation over 1 second. Demonstrate complete release of bag between ventilation. So the bag should be nicely collapsing and then re-expanding. That is the indication that the LMA is placed correctly. What is done here, and name the various structures that are shown here.
Canal block.
Very good. Any other name
Sir.
for that? Any other name for that? Alternate names for that? Which nerve you block?
Sir.
Which nerve you block in this adductor canal block?
Excuse me, sir. Navasami, sir. This is Dr. Prasanna, sir, from ICF. Sorry for interrupting, sir.
Okay.
Sir.
Tell me. I'm
No, sir.
hearing.
This is the previous LMA, sir. Just like make one small. This is regarding the previous LMA discussion, sir. Just one
Okay.
small correction I would like. Sorry for interrupting, sir.
Yeah. No problem. Tell me.
Sir, this integrity of the cuff, LMA cuff is usually
Your voice
testing the
is-
cuff. That's a difference between, sir, testing the integrity of the cuff. It's regarding testing the integrity of the cuff.
Yeah.
The integrity of LMA cuff is tested by deflating it, and endotracheal tube is tested by inflating the cuff, sir. That's a main difference because the cuff of LMA is usually in an inflated position. So further, if you inflate, you'll not be able to check whether it is leaking or not. So usually we deflate it, and if it is holding the pressure, then it means that the cuff is integrated. And if it is still inflated, then it means that the cuff, there is a leak in the cuff.
Okay.
So that's the main difference between checking the integrity of the cuff between LMA and the endotracheal tube.
Okay.
Endotracheal tube we inflate and check,
Yeah,
and LMA we deflate.
Yes.
Sorry for interrupting.
No problem. Thank you for that information.
Okay. Okay, sir. Okay.
Arun, what now you block in the adductor canal?
It is a terminal division of the femoral nerve, saphenous, sir.
Saphenous nerve block. Very good. Saphenous nerve block. So just remember the name of the nerve also. That is more important than saying it is an adductor canal block or sartorius block and all those things. It is the saphenous nerve that we will try to block. And can you name the various structures which are given in short form here?
Yes, sir. The boat-shaped top muscle is the sartorius, and
All the short form the alphabets you can expand.
yes, sir, femoral artery and femoral vein, and usually on the lateral aspect of the femoral artery will be having this saphenous nerve, sir. and it is medially by adductor magnus and adductor longus, sir,
Or longus.
and laterally by vastus group of muscle, mainly the vastus medialis.
Very good. Excellent. So this is a US ultrasound guided saphenous nerve block, okay, that is being performed, and the structures named are sartorius muscle, that is SAM, femoral artery, femoral vein. SAN is saphenous nerve, which you can see the needle is here, and the local anesthetic is being deposited here. Okay, so the needle has come inside like this. Then you have the adductor magnus muscle, which move lateral to femoral artery and femoral vein, and they have adductor longus muscle also. So longus and adductor magnus both are there. Then you have vastus medialis muscle. So these are all the short forms that are given. Now, what other names are there for this block? You already said adductor canal block. Do you know any other names? And saphenous nerve block is also another name. Any other name?
Subsartorial plexus.
Very good. It's also called subsartorius and adductor canal block. Okay. And what are the indications for this block?
As a postoperative analgesia for arthroscopic ACL PCL procedure, sir, meniscectomy. Postoperative total knee replacement as an analgesia, supplemental analgesia.
Okay. Now, what is the main difference between the other forms of analgesia and this analgesia?
Motor block won't be that severe, sir.
Motor block is not there. It's mainly sensory. Okay? So the block provides sensory blockade over anteromedial aspect of knee, medial aspect of leg and ankle. Hence used for analgesia for total knee replacement, ACL repair, open protection and internal fixation of ankle during post-op without motor block, helping to mobilize patients faster. Okay, so this is what is being in practice, so that after TKR, you can make the patient walk without any difficulty, without having any pain. So coming to the endotracheal tube intubation, what are the 5 advantages of using an endotracheal tube? Okay. The 5 P's. This is a basic question for even the juniors who are not exam goings. So the exam goings can answer this. What are the 5 P's or advantages of using the endotracheal tube? So much time for this. Too basic, is it? Any one point at least. Why we use the endotracheal tube every day? Any one answer.
Prevent aspiration.
Excellent one. What is the main purpose of your endotracheal intubation in the theatre, ma'am?
Guaranteed oxygenation.
Ventilation. You want to ventilate in a paralyzed patient or a patient who is not breathing, isn't it? Yeah? Positive pressure ventilation you are giving. You are preventing aspiration by putting the tube. You are keeping a flattened airway. Okay. Yeah? So ensures airway patency, protects against aspiration, allows positive pressure ventilation, allows suctioning, that is pulmonary toileting, and you can sometimes use them for pharmacological administration, like your dilating agents can be directly instilled through the endotracheal tube. So the 5 P's are patency, protection against aspiration, positive pressure ventilation, suctioning as a measure of pulmonary toileting, and pharmacological drug administration. Okay. What are the disadvantages? What complications can be produced by PG tube intubation?
Ventilator associated with pneumonia.
Commonest, when you try to intubate in a difficult intubation case, what can you do? Try through 2-3 attempts, you try to push it, you try to poke it into the glottis. What can you cross by that?
Injury to airway.
You can damage, isn't it? That is the most common things. And so insertion can be difficult. So you need muscle relaxants. You can cause laryngospasm by stimulating them in a very inadequate plane during incubation as well as extubation. And it causes sympathetic stress. Always it is associated with tachycardia and hypertension. So that are one of the disadvantages. How do you choose the size? What are the common sizes that are used for male, female, infant, like that? What is the common size you use for a male patient, adult male patient, average size adult male patient?
8 or 8.5.
8 to 9 size millimeter internal diameter. That should be the correct, complete answer. Okay, don't just say 8 or 9. 8 or 9, between 8 to 9 millimeter internal diameter tube for an adult male. For a female,
7 to 8
7 to
millimeter
8
internal.
millimeter internal diameter. For pediatric patients, how do you decide the size?
Formula age by 4 plus 4.
Age in years by 4 plus 4. Okay, age in years. Supposing you have a 6-year-old child, 6 by 4 plus 4. So 6 by 4 is 1.5 plus 4 is 5.5 millimeter internal diameter. Okay, if you have a 2-year-old child, 2 by 4 plus 4, that is 0.5 plus 4 is 4.5 millimeter internal diameter. Okay, so who prescribed this or who formulated this calculation for calculating the size of the tube? Earlier it was 2 different formula. Below 6 years one formula and 6 to 12 years was another formula. But one person cleverly combined both and produced a very simple formula to remember. Age in years by 4 plus 4 was introduced by Dr. Kester Brown of Australia. Kester, Kester Brown, a renowned pediatric anesthetist, he introduced that. Okay. So age by 4 plus 4 millimeter internal diameter is the formula to be used for pediatric patients. Now, indications, of course, ensure patency in an unconscious patient, protect lung from aspiration. You can give positive pressure ventilation in the setting of respiratory failure or during general anesthesia. So these are all the indications where you use it. Contraindications, any situation where pharynx is obstructed, like pharyngeal foreign body, massive swelling of the pharynx, or if there is serious maxillofacial trauma. In these conditions, it is difficult to contain. And complications you can produce are mainly displaced or mistaken size, especially in the apneic patient, and quickly lead to hypoxia and death. Accidental esophageal intubations, you can cause oropharyngeal trauma, you can break the tooth of the patient or dentures, and endobronchial intubation if you insert it too far. So, what is the protective mechanism or protective indicator in the endotracheal tube to prevent this endobronchial intubation, the last complication? What do you have in an ET tube? What marking is there and what is the name for that? Have you all seen a dark black line above the dual end which goes into the glottis? A circular dark line will be there before the markings start in the centimeters. Have you all seen that?
Yes, sir.
What is the marking called? It's called the vocal cord mark. Okay, so whenever if you are able to visualize, have a good view while intubating, you must stop at that level. You should not push the tube beyond that dark brown black thing that is marked on the ET tube. Okay, it's called vocal cord mark level. So don't push beyond that, you will be safe. What are the equipments needed for analytical intubation? This is a question for the junior most. Every day you are doing 1 or 2 GA cases in your theatre, isn't it? What are all the equipment? Laryngoscope, very good. Appropriate laryngoscope blade and laryngoscope handle. Okay, then
Working
Suctioning
suction
apparatus.
apparatus.
working suction apparatus. Okay,
Pharmacological drugs.
that's endotracheal tube you need. So after your PD tube, you will say endotracheal tube. And what instrument you need to guide the tube? Supposing you do a
Bougie, sir.
Stillet. Then, so this is common, no? The laryngoscope, a tube, a syringe to inflate the cuff, the oral airway. Then you may have difficult airway, you need endotracheal tube stillets or bougie, and you need very useful instrument. What is this?
Argues for sir.
Nagel's intubating forceps. What is the full name? Nagel's intubating forceps. Okay. Now I am showing you 2 pictures X-ray. Shown here are 2 X-rays with foreign body lodged in air passage. Where are they lodged and what will be the clinical presentation and how to anesthetize the patient with this foreign body? Usually it happens in pediatric patients. Now, where do you think is the foreign body in picture 1 and where do you think the foreign body in picture 2?
So in picture 1, it's around the glottis, larynx, means just beneath the vocal cords, trachea.
And the trachea, upper airway. What about the second one?
So it has gone into the primary or secondary bronchus. Sir. Means it has gone.
Mostly right side. The gone mostly on the right side, right bronchus. Okay, very good. So this shows foreign body in trachea. This is in the airway. That's picture number 1. How will you to know the exact level? You have to have a lateral view. Okay, so that is correct. Upper airway, foreign body. So what will be the clinical picture on that patient? Patient with foreign body in picture number 1.
So stridor, hoarseness, dyspnea.
Dyspnea. Okay, so the patient may have stridor, dyspnea, drooling of saliva, and desaturation. All these things will be there if it is the upper airway body. What about the second one? So if this first patient comes for foreign body removal, it is a more challenging thing because this is an emergency and there will be a full stomach problem, chances of complete airway obstruction, and you are going to share the airway with the surgeon. Okay? So the 3 problems or challenges you will be facing in this case will be because it's an life-threatening emergency, maybe a full stomach problem, airway complete obstruction, where you cannot ventilate or intubate, and sharing the airway with the surgeon. So you have to adjust your anesthesia in such a way that you have to give the entire airway to the surgeon at the same time maintain oxygenation of the patient. So this is a common problem that you come across in any foreign body, especially in the toddlers. Okay. So this question, if you ask, you have to recall all these things and answer that. Whereas with the second problem, that is a foreign body lodged in the distal part of the airway, what is going to be? So preservation of spontaneous breathing is mandatory for patient number 1. So you have to go for inhalation induction and maintain the deep plane of anesthesia. Okay? So that is the dictum that you have to follow. Whereas for the second one, it is lodged in the right main bronchus, which is lower airway. So the patient may be less symptomatic with mild cough or dyspnea and not an acute emergency. So how do you manage this patient? So always foreign body aspiration. In a pediatric case, you have to first divide whether it is an upper airway foreign body or a lower airway foreign body. The lower airway foreign bodies are less troublesome, whereas the upper airway foreign bodies are threatening and dangerous. So how do you manage the lower airway? Even if you intubate and ventilate the child, even if it goes further, what will happen? It will go and get infected somewhere. But the upper airway and the other lung complications are all patent. Okay? So there is no immediate danger in that. It may cause a little bit of collapse, then later on pneumonia and all those things, but this is not so life-threatening as this one. Okay. What you do is, this is a less emergent situation. Patient can be induced with IV agents. You can paralyze with neuromuscular blocking agent, and then hand over the patient to the surgeon. We can put in the bronchoscope and we can do jet ventilation in these cases. So jet ventilation is indicated only in lower airway foreign bodies, right? So that we have to do. So how to differentiate a circular foreign body lodged in the trachea from one that is lodged in the esophagus? How do they look like? Suppose we have a
It will appear oval shape in esophagus.
oval shape in
Esophagus.
esophagus, and it look like a vertical line in trachea. Okay, so a coin that has been swallowed, this is how it looks in the trachea, vertical line, whereas that has been swallowed in the esophagus will look round like this in the X-ray. Okay, even though when you go by a esophagoscope, it will look like that. Whereas in the X-ray, a tracheal coin will look vertical, a esophageal coin will look like a round shadow. We have other X-rays of the cervical spine here. Picture here is there. It's an X-ray of the neck. This is an X-ray of the head and neck and the chest. This is an X-ray marking the nose. Another X-ray here. X-ray see clearly to all of you, or is it blocking your view?
I can see it, sir. We can see it, sir.
You can see it fully. Okay. First, my view is blocked right now. So you have three pictures here: A, B, and C. Can you identify what is the problem in each of them? Have a nice look. I think they are fairly decent X-rays where you can identify. Jam, you have only 4 to 6 minutes to answer this.
So some sort of neck swelling is there in
Picture A.
picture A, sir. Yes, sir.
Yes, exactly. Very good. Very good. What about this one? You are right. Pratik. Correct. Okay. These two are same thing and enlarged and marked.
Diffuse swelling, which is going down, means up till mediastinal.
So it is entering to the thorax also. Correct?
Yes, sir.
Swelling entering the thorax. Okay. Yeah. What about the third one? So you have made out the swelling. Do you have to make out something else also in these pictures? Supposing you make up a swelling, what could be the swelling due to?
It could be thyroid swelling.
Thyroid, excellent. Thyroid swelling. So thyroid swelling, if it is there, what else you should look for in these X-rays?
With a retrosternal extension.
Very good. Whether it was retrosternal or only in the neck. Very good. Anything else more important than that?
Tracheal deviation or compression.
Airway. See, this is the first swelling where you can see the airway getting narrower from the above. This is the air shadow in the neck. Be able to appreciate that?
Yes, sir.
Okay. And this is another X-ray showing a swelling here as well as in the mediastinum or retrosternal. And can you see the air shadow getting
Yes, sir.
wavy here? And this has been outlined and marked nicely for you. Can you see this air shadow? That is, the trachea is dividing into two. Can you see the difference in the air shadow? Here it is broader, it is narrower, and it has been pushed away from the midline. Okay, so this is the yellow marking dotted line is the shadow of the swelling. This is the aorta. Okay, so there is a deviation, and in this case, what is the third difference one? They are shown both the frontal as well as the lateral view. You are seeing a nice swelling on the lateral view, and also there is a compression. This lateral view shows a compression of the airway. So this is what we have to look for very importantly. So the differences in the above X-ray of three different patients. In what way patient B be more challenging, and how are the pressures on the trachea described? These are all the questions that will be asked in the endovascular. So A is a lateral view of the neck with a soft tissue swelling, probably arising from thyroid, with compression of the trachea seen from C6 to C7 level. So all this description you have to know. See, these are all the vertebral bodies. So last one will be the C6 and C7 level. That is where you have the swelling, and the airway, as I told you, broader here and getting narrower here. So there is a compression of the trachea seen at C6, C7 level because of probably thyroid swelling. That is what the description for A. And B, there is a frontal view of the neck and chest showing retrosternal extension with compression and the deviation. So it is not only compression but also deviation. Both the things you can see. So here it is compressed and then narrow. Here it has been pushed extremely to the right. And in C shows both frontal and lateral views of the neck with soft tissue swelling with minimal indentation of the trachea. Very minimal indentation is really there. It is almost slightly reduced side. So compression, indentation, deviation. These are the three ways you can describe the effects of the swelling arising in the neck or the air canal causing on the airway. Compression, indentation, and deviation. This is picture A. The picture B. So what do you see in these two X-rays?
Bubble shadows in the thorax.
Very
That
good.
could be a congenital diaphragmatic hernia.
Okay. So both pictures are the same?
No.
So you have to say exactly which side. And so
Picture A is a congenital diaphragmatic hernia.
can it be dramatic? Is it looking like an adult X-ray or a child
It's
X-ray?
adult, it is looking more like an adult X-ray, sir.
Dilated.
So that can
Traumatic.
be a dramatic.
Not romantic.
Whereas this is the right-sided diaphragmatic hernia. Again, bubble shadows are seen on the right side. Okay. So A is left-sided diaphragmatic hernia with bowel loops inside the chest, and B is right-side diaphragmatic hernia with bowel loops in the right thorax. Which side is more common, and what is the frequency of occurrence? Which is more common, right or left? Especially if it is a congenital. Left is more common. Okay. So left sided is more common, occurs 1 in 3,000 to 4,000 live births. Prepare a CDH in emergency. What factors decide the success of the surgery? We have to immediately operate on a baby born with a congenital diaphragmatic hernia on the first day of birth, or you have to wait, you can wait and do the class taken on congenital pediatric emergencies. So it is not an emergency at all. Okay. Diagnosis made even in the antenatal period by an ultrasound examination of the mother. Okay. So usually you know the diagnosis even before the baby is born. What is the most important evaluation you should make in such patients with the diagnosis of possible CTH, congenital lateral. What is
Respiratory
all the bowels come into the thorax instead of pain in the abdomen during the days of development in respiratory life? What will it cause? Supposing
Pulmonary hypoplasia.
Pulmonary hypoplasia, excellent. That is the most important thing. It may not allow that lung to develop because both are developing, both are growing inside the womb. So instead of staying inside the abdominal compartment, if it is because of the gap in the diaphragm, if all the bowel moves into the lung, it will not allow the lung to develop and mature. So there may be a rudimentary lung. If it is a rudimentary lung, the prognosis is very bad. On the contrary, if the lung has nicely developed side by side along with a small amount of pleural herniation into the thorax, that baby will do very well. So you have to assess the maturity and development of the lung to decide whether the child will stand the surgery or not. If it is a well-developed lung but only compressed by the bowel that has been moving into the thorax, you can intubate the child and mechanically ventilate and try to push all those things by pressure and then take up the child for surgery. The surgery is to repair the defect in the diaphragm so that the hernia can be reduce all the contents back into the abdomen, close the defect in the diaphragm fecal tissue. Okay, so the success depends only on the maturity and development of the lung. If the lung is well developed, the survival rate is almost 100%. The lung is rudimentary, then what are the problems that will produce if the lung is not well developed? After the birth, the baby starts breathing. So what will happen? The normal side lung is well developed, but the herniated side lung is not well developed. So what effects will be caused by that? There will be pulmonary hypertension because the vasculature is also not well developed. Okay? So the fluid volume is entirely borne by the normal lung vasculature. So they will invariably have severe pulmonary hypertension and right heart strain will be there. So you have to reduce the pulmonary hypertension. That only will decide how the surgery will be there. So what challenges are there in the anesthesia? How to optimize all the common. What are the waveform shows here? Can you identify these waveforms? We all there?
Wave from the left atrium,
Yeah.
ventricle, second is ventricle. Third, fourth is
Get all these waveforms. When will you see all these
pulmonary. In pulmonary artery catheterization, you will get all.
Simple. All those who have worked in cardiac papers will write it in no time. They show the waveforms during the passage of pulmonary artery catheter. A is right atrium, B is right ventricle, C is main pulmonary artery, D is pulmonary capillary wedge. Okay. So when you get the waveform like this, you start pushing it further. So you have seen Subson introducing the PA catheter will be always watching the monitor to see for the waveform. So once you get here and the pressure is between 5 and 10, you stop. So you know the pressure is also here. Okay. So main pulmonary artery pressure we get up to 20, then the right ventricle goes up to 30, and the right atrium will be 5 to 5. Okay. So the pressures are also displayed here. Okay. So what are the pressures at this site? Because they are all very obviously visible. Right atrium between 2 to 6 millimeter, right ventricle 20 to 30, that's systolic, and 0 to 5 diastolic. PA pressure 20 to 30 systolic and 5 to 15 diastolic. Pulmonary capillary leak pressure between 4 to 12 millimeters of mercury. Okay. What are the lengths at which these sites are reached by a PA catheter by various routes of insertion? There are markings on the PA catheter to show you where exactly you are now. Okay. From the tip. So distance to right atrium is about 10 to 15 centimeter by supply range route, 15 to 20 centimeter from IJV, and 30 to 40 centimeter from femoral vein. Right ventricle is another 10 centimeter, pulmonary artery is another 10 centimeter, and wedge position is another 30. So 30, if it is supply vein, totally it will be 45. For IJV, it will be somewhere between 55 and 60. And for femoral route, it will be almost 60 to 70. So this is the catheter all of you would have seen. If there are the case how it is introduced. It's also known as Van Der catheter or yellow snakes. What are the uses? Can you recall the uses or indications for its use? Where do you use? These questions and how will be answered very fast.
Cardiac output monitoring
Ah,
by thermal dilution technique.
okay. That's the only one. So continuous cardiac output monitoring, central temperature monitoring, measurement of pulmonary artery pressure, also RA, RB pressures, but you can say venous saturation. The new thing, for example, for assessing the state of saturation. And there is situation of diastolic filling of the indirect system of feasibility is an indirect surrogate marker. Okay, commonly used right ventricular pressure, pulmonary tension, bleeding in cardiac artery, and post cardiac delivery. Available in number of sizes for adults and children, ranging from 60 to 110 centimeters, 4 to 8 inch in caliber. Volume increase in volume is 0.5. Made of polyvinyl chloride, has slightly at room temperature and softens at room temperature. It is not a 10 centimeter increment to 8 insertion. It will vary depending upon the manufacturer, but basically they are quadruple human. Thermodilation gas, the blue human is for right atrial, functional indicate port, terminates at 10 to 15 fits. And the port can monitor RA pressure. It indicate for cardiac output studies. The red and white connectors include temperature sensitive wire that terminates 4 centimeter transfer the terminal port. So all of you know all these things. White functional infusion port, yellow pulmonary artery, critical port, red for pulmonary infusion. The other addition, sometimes you may have dosing capabilities, fiber optic for inflating the prostate circulation, and thermodilution for continuous cardiac output. So all of you would have seen these bottles in your body. What are they? What is it used for? It is shown here and where they are used.
URP.
Yeah.
Irrigation fluids, sir, used in
Yes.
various surgeries like TRP and
Yeah.
bubble wash in laparoscopic surgery. ACL repair.
Shown here are 3-liter plastic bottles of normal saline. That is the red label one, and 1.5% glycerin, green label one. Okay? So that is how you have to say what is the what capacity bottle, what is not the glass, what is the content. So 1.5% glycerin is used for PURP and PCRE. What is PCRE? The idea what is TCRE?
Transcervical resection of endometrium, sir.
Excellent gynecological indication. For DUB, they used to try this. Nowadays, given up. So instead of doing hysterectomy, they were trying to coagulate and desiccate all the endometrial layer which was bleeding in dysfunctional uterine periods. So for a time they started using this technique of coagulating the entire it's called transcervical resection of endometrium. Okay. So normal saline indication is used even in arthroscopic surgery and more to the what are the advantages and disadvantages using glycine? Maybe the additional question if it is examination. Why someone prefer glycine instead of saline? So especially to your food.
So saline is a ionic fluid, means during cauterization it will
Current will get dispersed.
it will be dispersed. Glycine provide a good field of vision because it has a high refractive index. Sir.
That's advantage. But what are the disadvantages?
So we are using hypotonic solution of glycine. So that will cause means TURP syndrome when a fluid enters the sinuses, prostatic sinuses.
What does glycine absorption into the body apart from the common complication? Glycine absorption.
So glycine will be metabolized as urea and
Glycine directly, does it not have any action on the subclavian system?
It's a major inhibitory neurotransmitter.
neurotransmitter. Yes, sir.
Neurotransmitter. So advantages are naturally available amino acid, lower cost, current dispersal is good, clear vision for surgeon. Whereas disadvantage is inhibitory transmitter, hypoosmolar, and then absorbed through the vein, transient vision loss, one of the important complications of glycine irrigation. So this is how the tool will be there. From here, this Molar. So the normal way TURP is done. You find that loose
Using cautery, sir, electrocautery.
This is not electrocautery. There is a reflection of some glowing light here. We get
Laser.
light. It is a laser resection of the
Chromium laser or something.
So
Chromium laser.
chromium laser enucleation of prostate.
Inoculation.
Is seen in these pictures. All the things, any X-ray when it is given, you should start describing the X-ray. Whether it is X-ray chest creating view, laparoscopic view, bony things, soft tissue. The description of the X-ray is very important. Do you think it's an APV or a PAV?
APV.
APV, sir.
APV. Why APV?
Scapulas.
What is the difference between PA view and the AP view? Which structures will be seen better in PA view and which structure will be seen better in AP view? What is the basic dictum to assess X-ray penetration and X-ray? All structures closer to the X-ray plate will be seen better. So if you take a PA view, that is, you project the X-ray beam from the posterior to the anterior and keep the plate in the front of the patient, your heart and other lung shadows will be seen better here. Okay, because they are closer to the X-ray plate. But in an ICU patient, you cannot do that. You cannot project the X-ray beam from the posterior angle, from the back. So you always keep the plate under the patient's back, then give the X-ray beam from the top. So the spinal vertebral column will be closer to the X-ray plate. So if you see the vertebral shadow much better, it is always a AP view. The X-rays are projected from the front of the chest and they are falling on the X-ray plate kept at the back of the patient. Okay. So if you see the vertebral body is more prominently, it conveys the antero-posterior view. You see the cardiac shadows and lung shadows better, it is the posterior-anterior view that is taken especially in the erect posture, will be much better. So normally we take a PA view, but in ICU we normally take a AP view because we cannot make the patient stand up or sit up for a long time. So this is the AP view. So what are the things that you are seeing? Just describe whatever you are seeing.
Right.
The markings are all very clear here.
No,
Lung field up is hazy.
It's an X-ray test. Still not PA, it should be AP view. Shows diffuse opacities in both lobe, KG lead wires crisscrossing, and you are also seeing a ND tube going down. Okay. So that much of findings are there. This is a CT scan of the same patient. What do you see in this? The patient shows ground glass opacities on the right side. Around the ground glass opacities. It's a consolidation on the left side. This is a COVID. It will be very easy to identify a COVID. What is the Coraz score? Radiology score, Coraz score. Okay. It's a radiological method of assessing. Forgotten, no? Number of cases of COVID has come down, so you have forgotten what happened last year. The severity of COVID-19 infection combined the CT findings with the RT-PCR results. That is called the Coraz score. It's graded from 1 to 6 with low to severe infection. So now you are the Coraz 1 CT findings are normal, non-infectious. There is no level of suspicion. Coraz 2 normal to consistent with infection other than COVID-19. And 3 is indeterminate. Here COVID-19 not whether present or not. Coraz 4 is high suspicion. The abnormality is suspicious of COVID-19. 5 is very high, typical COVID, and 6 PCR also positive. So in all other things, PCR may not be positive, but still basically its findings are good enough. It is being done here, shown in this picture. What are the treatment of COVID? All of you would have done.
Prone positioning, sir.
Prone ventilation. What are the challenges in prone ventilation and how to do it? The challenges. Have you all experienced prone ventilation? An intubated patient in ICU during COVID times? I have seen it only in pictures, because I have not been practicing this. Some of you should be stalwarts and experts in doing that. So 5 P's you have to remember: plan, prepare, perform, protect, and perfect. Okay, so the 5 P's that are done. So you need adequate personnel. 7 personnel are required. Okay, so plan. Team, who's going to be the team leader? Team know movements. All of them, they know what their position, how they have to act, and which direction you are going to turn, right or left. The number of movements you have to perform. It's lifting the patient from supine 1, 2, 3, like that. So these 4 questions should be planned. Who is going to be the leader? And all the members of the team, do they know what their role, how they have to move? Which direction you are going to turn from right lateral to right lateral or left lateral, and how many number of movements you are going to do. This is the plan that you have to form. Then you have to prepare. At least 7 personnel, like 1 slide sheet, 6 pillows, bed sheet, print bag, eye tape, pads, eye ECE dots, tube tie, figure for closing the urinary catheter, and jelly. All these things should be kept ready, prepared. And perform, count in and go. That is, you have to say 1, 2, 3, and then shift the patient. Okay? Check the ventilation, reconnect all monitors once completed. Then protect the pressure points. Ensure no tables or trap tables or catheters. Rotate head every 2 hours to ensure the raised arm is swapped frequently. That is a perfect thing. So the pillow is in the central position, unpaired abdominal expansion is there, whether the toes are off the bed without compression, and head and tubes, PP tube, NG tube, they are all in position. Patients head on jelly or bean bag, eyes and nose free from pressure, ventilation okay, catheter reconnected, running, arms pressure points no over symptoms. So all these points you remember, you can easily answer. Those who are going to appear for theory also, from ventilation may be a short note question, so you can answer all these things from this one. The defect seen in these X-rays and how to read it. First of all, identify what these X-rays are. Which part of the body has been X-rayed. Please leave the answer. Which part of the body it has been X-rayed? At least answer that question.
Neck X-ray
X-ray neck, yeah, both the AP and the lateral. Can't it say that also? So there is a, you can see this body of the vertebra, is it in alignment? So there is a deviation and there is somewhat distortion of the air shadow in the tracheal air shadow also is there. Okay? So whenever you see the lateral, you have to draw these lines. See, this is called the spino-laminar line. So all the spines in laminar. This is the posterior of the body of the vertebra posterior. This is the anterior of the pre-vertebral. This is how you assess the position of the bony structures in the lateral view of the neck. So if you use these guidelines, do you find this spino-laminar line in alignment here? Are they learning in a single line like this? This body, does it look or come in the line along with this, or it is a little bit backward? It has been pushed backward. Okay, so that has been gone back. So on the spinous process, everything has moved away. Okay, so there is a dislocation. So anterior cortex line, posterior cortex line, and spinal laminar line are all disrupted due to fracture and dislocation of C6 vertebra. Okay? So C6 vertebra is fractured and dislocated. So if there is injury to spinal cord at this level, what will be the clinical presentation and how will you manage? The trauma scenario, the spinal cord injury, spinal vertebral injury at C6 level. What can happen? The patient has respiratory paralysis. The diaphragm be working or not?
Diaphragm will not work, sir.
Diaphragm won't work, is it? What is the root value of diaphragm? In the phrenic nerve, that is up. C3 to C5, isn't it?
Yes, sir.
The diaphragm will be spared. Phrenic nerve is spared, isn't it? So C6 is below. First to do a ABC survey, that is airway breathing circulation. Next is to immobilize the cervical spine and secure the airway by a rapid sequence injection. Manual inline stabilization. Look for associated injuries, specifically in pneumothorax. Next to secure a large bore IV access and send lymphadenopathy and hematology biochemistry and chain. If any overt hemorrhage is seen, try to control it and resuscitate by volume replacement. No obvious bleeding is found. Avoid aggressive fluid therapy. Why you should avoid aggressive fluid therapy or cervical cord injury? Patients are prone for neurogenic mortality. Any reason for early intubation is hematoma in the neck may cause airway infection. When the injury is above T1 level, cause disruption of sympathetic supply resulting in hypotension and bradycardia. And it's shown in this picture.
Spine board, sir.
Spine board, excellent. First shown is a spine board commonly used in trauma team. These two, they are also used for similar purpose, but this is a modern version. In what way it is different from the one what you are seeing on the left. This is the older version, thick plastic or thick fiberglass board. Okay, whereas here, can you see what is happening to this here? You can bend this, whereas this board is fixed board. Okay, so you can bend it here at the knee so that calf compression will not happen. Okay, venous return will be aided, and it has handles which can be moved by a single person. So after applying all the straps, you can rotate the person for any maneuvers. So the other two show new invention called vacuum spine board and how it is used. What is shown here and can you name them? Parts of the body are being pointed out. Lines are jetting out.
Endocrine system of body,
Excellent.
pineal gland, thyroid,
Thyroid.
adrenal, ovary, and ANF secreting heart.
You have not mentioned this one. You said thyroid, you have said pituitary, yet not
Pineal.
Pituitary is small. Pituitary, thyroid, adrenal, ovary, testis. What about this?
ANF secreting.
PNS. Normal endocrine gland. Very much. Okay. It's shown all the endocrine glands in the human body. So you have pituitary,
Thymus.
parathyroid, thyroid, thymus gland, adrenal, pancreas, ovary, and testis. Okay. That's all this thing. What is the function of the endocrine system? What does it do? Kamachi, tell me if the other class is going to get delayed. I can stop by any time you want. Kamachi,
Yes, sir. Yes, sir. Yes, sir. Okay, sir.
just caution me if I'm careful.
Okay. Okay.
The endocrine system is concerned with the basal process like metabolism, growth, and reproduction. So in combination with nervous system, it allows signaling between different parts of the body. So what are the structures of hormones? How they are made up of? Hormones are classified into three different groups based on the structure. Is now when you just name them. These are all basic physiology questions. Sometimes that may come. Let's say derivatives of single amino acids like pyroxene and catecholamine. What is the amino acid from which they are derived? Common to both. Tyrosine. Have you not heard of that word? Tyrosine. Tyrosine is the basic amino acid for both thyroxine and catecholamine. Polypeptide chains having amino acid and carbohydrate like growth hormone and insulin. Steroid hormones like steroid nuclease, aldosterone, and cortisol. So these are the structural classification of hormones. Single amino acid, polypeptide with carbohydrate chain, steroid. So how do hormones act? What is their mechanism of action? Each hormone has a specific receptor on their target cells, which can be intracellular or membrane bound. Fat-soluble hormones like steroid hormones act on intracellular nuclear receptors. Water-soluble ones act on the membrane receptors like tyrosine kinase or G-protein coupled receptors. These three mechanisms, one is nuclear receptors, or second membrane bound, which is classified as tyrosine kinase or G-protein coupled. Some basic physiology and describe neuromuscular transmission. This is a very easy question. So how can you answer this? How does the normal neuromuscular transmission take place? The whole class is silent. Very, very common basic question. Arun, you are also not answering. Are you there? I have shown the picture also. Now at least you can start the description.
Action potential reaching the neuromuscular junction,
Yes, good.
causing opening of endocrine receptors and calcium release and contraction, and calcium will bind to the acetylcholine receptors and causes acetylcholine release. The acetylcholine will reach in the muscle. Sorry.
Muscle, but neuromuscular junction. Wow. How is the acetylcholine released from the neuronal end? Presynaptic area.
By exocytosis of the vesicle receptor.
For that, which is what is very, very important, shown in this picture. For the
Sodium
sodium. Calcium. See, closed voltage gated calcium channel. So calcium first must enter here. Then only it can allow the vesicles to come to the presynaptic junction area. Then they will be broken. Then acetylcholine will get released into the.
And they will bind to the.
They will bind to the acetylcholine receptors here on the peak of that, and immediately after one action, they will be broken down by the acetylcholine space where the come. So this will be transmitting to the motor end plate where it is implanted. That is the whole process. The common thing that you want to do. What is the safe time period to use Osce in patients with burns?
Up to 72 hours.
24 to 48 hours, and then after healing, some would say 6 months now, some would say 9 months, varying answers. Okay? It is phase 2 block. With which much neuromuscular block will probably will get phase 2 block. Our theory need to be refreshed badly. To block, there is a same. What is ganglion sodium? What are the implications?
Dantrolene sodium used for malignant hyperthermia.
What nature of drug is it? What category of drug it belongs to? Ganglion sodium. It's also a muscle relaxant. Okay. Even though you commonly depolarizing and non-depolarizing muscle relaxant, dantrolene sodium also does the same thing, but in a different mechanism. So, what does it do in malignant hyperthermia? What is exactly the pathophysiology of malignant hyperthermia? This is where your ryanodine receptor comes into play. Genetic mutation of the ryanodine receptor results in the opening of the sarcoplasmic reticulum without closure. Normally, when a stimulus comes from the neuronal end passing through the synaptic plug to the motor end plate, it will allow the sodium to enter into the circle, the muscle fiber cells, okay, circle cells. And once they come inside, it allows the calcium also to enter through the T channels. The entry of calcium through the T channels into the muscle cell will make the granule receptor open and then allow more calcium to come into the cytosolic space from the sarcoplasmic reticulum. Okay, this calcium will stimulate the troponin C, which will go and stimulate the fusion of or contraction coupling of the actin myosin complex. Okay, so after the stimulus is over, this calcium will go back into the sarcoplasmic reticulum and rhinodine receptor will close so that the contraction is terminated. So troponin I will start working, it will inhibit this coupling and it will release the coupling of actin and myosin. That is what will happen once the stimulus is gone. This normal physiological phenomena is altered in malignant hyperthermia because the rhinodine receptor, which opens to allow the sarcoplasmic calcium to come into the cytosolic aspect, is not able to close back. So there is a continuous extrusion of calcium into the cytosolic place, resulting in the permanent or the sustained contraction of the actin myosin complex. This contraction produces rigidity, severe heat, and then the patient's temperature goes up. So Dantrolene, what it will do is it will push back the rhinodine receptor into its original place and it will allow the calcium to get back into the sarcoplasmic reticulum so that the routine physiological inhibition by the troponin I can cause uncoupling and then the relaxation. Without the Dantrolene works. Okay? So it is used in all conditions where you want to have even cerebral palsy cases, some of them respond well to that. And dosages, any idea what is the dose of Dantrolene? Milligrams per kg body weight. 3 milligram per kg body weight. It comes in 20 milligram vial. So for a patient with 70 kg, you have to give almost I mean, 10 mil, you have to resolve at least 20 vials per patient. So it takes a long time. So you need help. Composition of that is with mannitol and saline. So it is 60 ml of water to be used for dissolving each vial. It takes a long time. So how do you treat stolen apnea? See, after administration of dexamethasone, patient is not breathing. We make a diagnosis of stolen apnea. How do you treat that? Okay, because
Plasma
people are scared.
plasmapheresis,
Very
plasma fresh.
So just
see, it is mainly because of the, what is the reason for stolen apnea?
Deficiency of pseudocholinesterase or
Deficiency or the, again, mutation. So not able to metabolize these succinylcholine. Okay, so for plasma cholinesterase enzyme is not, it's defective. You're not able to metabolize or hydrolyze the succinylcholine into phenyl monocholine and succinic acid and choline. That is the step. Metabolism is by first rapid hydrolysis from succinyl dicholine to monocholine, then from monocholine to succinic acid and choline. So this is done by the enzyme plasma cholinesterase. In patients who have genetic abnormality of plasma cholinesterase, they will not be able to carry out this process. So dexamethasone continues to occupy the neuromuscular junction and the prolonged effect of the paralysis continues. So you have to support the ventilation until the serum level falls and the drug gets dislodged from there, or you can transfuse fresh frozen plasma which may contain normal plasma cholinesterase, which may go and metabolize or hydrolyze this drug. Okay, so mainly supportive treatment, and if the patient surgery is over, patient is likely to become aware and conscious that may cause tachycardia and hypertension. So if you diagnose the spleen apnea, you have to maintain some form of awareness prevention, either by maintaining anesthesia or by giving electrolyte stance, so that the patient does not become aware and remain paralyzed or get agitated. Name one more recent reversal agent and its mechanism of action, which is not still available here. Can you just name one?
Sugammadex, sir.
Sugammadex is already popular. That is not recent. Alabadia. There is another thing, Alabadia. Okay. Can you identify the parts of this shown in this picture? Name the parts of a typical vertebra. Even juniors also can answer. Part of the answers are shown in the picture itself. I have tried to hide them, but still can get the clue from pictures. What is this portion? My pointer. Are you able to see my pointer moving?
Body of the lumbar
This is
vertebra.
the body of a vertebra. We don't have lumbar or the pectoral or the body. This is a typical vertebra. So this is a body of the vertebra. Okay. What about this portion? Connecting the body. What is this portion? First, let us say this portion.
Transverse process.
Transverse process, which is
Spinous process.
spinous process. So, like a trident, first you remember a two transverse process and one spinous process. So, these things have to be connected with each other. So, transverse process and body, how are they connected?
Pedicle, sir. Pedicle of the vertebra.
Pedicle. Is it called pedicle? It's pedicle. Okay. What about this? This portion connecting the transverse and the spinous process with gap. This is the lamina, okay, and this is the articular facet. Okay? These are all the things. So, how many processes are there? There are three: spinous process, transverse process. Okay? So, this is the posterior superior iliac spine, posterior superior. What is this picture showing? This approach to the subarachnoid space. Normally, when you want to do an LP, you go between the L2, L3 or L3, L4 space. But here, where are you going? The spinal needle, where is it entering? What is this anatomy part? The entire thing. Patient is showing his back. These are the posterior superior iliac spines. This is the which portion of the back is this? Can you see my pointer moving?
Cossex, sir.
This is sacrum.
Sacrum and cossex, sir.
Yeah, coccyx is there. I'm showing the entire thing. This is sacrum. So, which vertebra should be this?
L5.
L5. So, the gap between L5 and sacrum, you are trying to enter. What is this?
Body.
What is this approach?
Taylor's
called?
approach.
Taylor's approach. Wow. So, here, how useful it is. It is useful in patients with any problem at all. What is the CNS to cardiac to circular toxicity ratio? This is with regard to the local anesthetic toxicity. CC or cardiac toxicity to central system toxicity ratio. Supposing you by mistake administer a toxic dose of local anesthetic, or the normal dose gets absorbed through a vascular channel and becomes toxic, what will be the first evidence of toxicity? Will it be CNS manifestation or cardiac manifestation? Last is a very common question. Not local anesthetic, systemic neurological. Yes. So what will be the neurological presentation?
Perioral tingling sensation will be.
Perioral numbness, excitation, then seizure, collapse, coma. Okay, these will be the series.
Asked brady and hypotension.
After
Brady,
that only we will
asthenia.
find yeah, so first is CNS manifestations will be soon followed by cardiac manifestations. Okay, so the dose required to produce the CNS toxicity compared to the dose required to produce cardiac toxicity is called the toxicity ratio. So there is a common very important message that you should know. So what is the toxicity ratio for lignocaine and what is the toxicity ratio for bupivacaine? Why bupivacaine is considered as more dangerous drug? The toxicity ratio for bupivacaine is 7. I mean, lignocaine is 7. Bupivacaine is 3. That means you require 7 times more drug in the serum or plasma to produce cardiac toxicity even when the CNS toxicity has happened in the patient. Whereas you require only 3 times more the concentration of bupivacaine to produce cardiac toxicity. Okay, that is why the recent introduction of levobupivacaine, which has got a toxicity ratio of 5. That means you require 5 times more of bupivacaine to produce the cardiac toxicity of bradycardia, cardiac arrest. So this is a very important point of lignocaine cardiac toxicity ratio 7, levobupivacaine 5, and ropivacaine also 6. Racemic bupivacaine is 3. That is why it is considered as. How will you diagnose and treat total spinal? Supposing you are trying epidural. By mistake, you have injected all the drug into the subarachnoid space. It will happen to the patient. He develops what is called total spinal anesthesia. Encountered a total spinal, we try to learn epidural so far. Everybody is the same anesthetist in this crowd. Right, try to read that. I don't want to be spoon feeding all these questions of that. What is this? What are you seeing in this? My God, I think these things will be ranching out immediately. We don't see
Dial sitting at 5.
Then what? Which dial? Which particular vaporizer dial is this?
Desflurin, sir.
Desflurin. And what does the T here indicate? The
Transport, sir. For
transport position. So what is this 0 indicating? It is in off position or
no
on
flow
position?
through off position.
So what features of Desflurin vaporizer and why you need it? What are the features of Desflurin vaporizer and why you need a special vaporizer for Desflurin?
Because of the low boiling point of desflurin, you need an external supply for
Because of
increasing
low
the
boiling
temperature.
point only, or some other feature is also there? This is the
High
saturated
vapor pressure and low boiling point.
Is saturated.
vapor pressure. So you cannot use the normal flow. So what is the difference in the other vaporizers and this vaporizer? What does it do? What is the major difference you will say? In other vaporizers,
Supply.
The fresh gas flow is sent into the vaporizer in other vaporizers to pick up the vapor. Isn't it? Partially by a splitting
sir.
ratio, part of it will go straight, part of it will go through the vaporizer to pick up the vapor and produce the desired concentration. Whereas in gas flow range, the vapor is injected into the fresh gas flow. No fresh gas flow directly enters the vaporizer at all. Okay, so by a special heating element, the vapor is formed in this vaporizer, and this will go and join the fresh gas flow. And to know what amount only to be injected, this is rather an injected type of vaporizer. Okay, so to adjust that pressure concentration that you set in the dial, there is a what is called the differential transducer is there. That is the most important point that once you that is functioning, that will adjust the amount of vapor that has to enter and mix with the mainstream of fresh gas flow. Okay. What is it being done here?
Filling of vaporizer.
Filling up what vaporizer? Color coding.
ISO with
Isofluorine.
rapid.
And what is the mechanism of filling of this vaporizer called?
Keyed vaporizer. Keyed
Keyed
vaporizer.
filling. Yes. Keyed filling. What are the other modes of filling you know?
Rapid fill, quick fill, sir.
Rapid fill, quick fill, direct flow. What is shown here?
Supplement vendor.
சொல்லுங்க தைரியமா சொல்லுங்க no it's not exam. I'm not going to fail you for you pass. So whatever you want to, even if you want to guess, you can guess. I'm showing both the pictures.
Subclavian vein cannulation.
Subclavian vein cannulation. Ultrasound images of IJV. Okay. So imaging of subclavian in transverse, and this is the subclavian IJV transmission. This first picture is the IJV. Okay. So this is the subclavian vein cannulation. Okay. This is the probe position and pushing the needle. So the subclavian artery, What are the landmarks for IJV cannulation? In the absence of ultrasound. All of you will be very well versed in IJV cannulation. So you must be knowing what are the common landmarks that you want to identify before the line technique. One landmark technique, so called. What are the muscles you should identify? What are the bony points you should identify? What is the joining line you should identify? These are all the things that you have to think of and write. Okay, landmark technique. So what are the indications, advantages, and disadvantages of subclavian vein cannulation? What is the most important indication for subclavian vein cannulation? Is it for temporary use or for long-term use?
Prolonged ventilation patient who is prone for tracheostomy. So long-term usage.
Long-term usage for those patients
Neurosurgery patients.
or parenteral nutrition patients. Okay? They also or chemotherapy patients where you want to give chemotherapy. So repeatedly function the veins. All these are the indications. So whenever you want to keep the cannula for a longer duration time, you go for subclavian. For the more comfortable, get the neck anyway, want less chances of infection. But what are the dangers to try to do? Why subclavian is not commonly practiced? What are the complications you can produce?
More chance of pneumothorax.
Pneumothorax and hemorrhage.
Then
Hemorrhage is
if there is
difficult to control.
hemorrhage.
Okay, if you puncture the artery and you under the clavicle, you cannot apply compression. Whereas IJV, even if you puncture directly, you can apply compression for some time and stop the hemorrhage. Okay, so these are common things. It's shown here is the need for infection in the practice. Can you just looking at these jars, can you first identify what could it be, even if you have not seen it?
CO2 absorbers.
CO2 absorber. These are all canisters which can be directly fitted into the machine. Okay. So the spiralate calcium. Okay. And there are new CO2 absorbents, spiralate calcium, spiral calcium or litholine containing lithium hydroxide. They have been introduced to eliminate the following drawbacks of soda lime. So there is no sodium hydroxide and potassium hydroxide. So formation of compound DA and carbon monoxide are not there. No heat production since there is no exothermic reaction. No dust or powder formation and they are more solid. The above property also prevents channeling of the gases, which can formally the soda lime. Color change on exhaustion is permanent and easily visible. Okay. There are the advantages of the newer CO2 absorber. And that is how the color will look like. Once the color changes, it will be nice purple, which will be easily seen through the top of the canister. 18 years old Aspiration Asian male with a known case of sickle cell anemia being coming with fever, vomiting, rightly and of pain for 3 days. On examination, he looks ill, pulse is 130, BP 80 by 54, temperature 39.8. And examination shows hemoglobin 8 grams, intergrade 32, urea 45, creatinine 1.2, electrolyte sodium 58, chloride 90, bicarbonate 44, potassium 3.2. The ABG is 7.53, PaCO2 67, PaO2 55. Interpret the values of ABG and electrolytes. What are the steps in analyzing an ABG report? Which is the value you should first look at?
pH.
pH. Is it normal or abnormal in this case?
Abnormal, sir. Increased, sir.
Abnormal.
Alkalosis.
Is it alkalitic side? Isn't it? 7.35 to 7.45 is the normal value. So more than 7.45 is alkalosis. Okay. What about PCO2?
It is increased, sir.
It is increased 35 to 45, 40 plus or minus 5. It's the PCO2 normal. Here it is 67. So hypercarbia is there. What about bicarbonate?
It is also increased, sir. It
is
is
also
22
increased.
plus or minus 4.
So it is 44. So what is the primary pathology here? Is it respiratory or metabolic?
Metabolic alkalosis.
Metabolic. So metabolic, it is on the alkaline
Metabolic
side. So it is the primary metabolic alkalosis. So is there any compensation for that?
Yes. There is respiratory acidosis and compensation.
Respiratory acidosis is there. So PaO2 55 is it normal? We can do here. We do not know that information. No. Even if it is room air, it is low. So patient is in metabolic alkalosis with compensated respiratory acidosis with the hypoxemia. And what about its alkaline sodium? Is it normal? 158?
Hypernatremia.
Hypernatremia. What about chloride?
It's normal.
There's a slight reduction in chloride. 95 to 100 is supposed to be normal. Okay, 90. Potassium 3.2. 3.5 to 5.5 is normal potassium. So there is a mild hypokalemia also. Okay. So patient may be nobody occupied the patient before surgery. So it is in respiratory and metabolic alkalosis with respiratory acidosis with hypoxemia with hypernatremia, probably is dehydrated. Okay, so you have to hydrate the patient well. So what complications can sickle cell produce? Sickling and thrombosis. Okay, so what is the difference between sickle cell disease and trait, and how this is identified? Sickle cell trait is a heterozygous or homozygous. If both parents give their gene to produce the disease, it is a sickle cell disease. It will be homozygous. Whereas if one patient only is giving, the other one gives a normal gene, then it's called heterozygous, and it will be only manifested as a sickle trait. And you have sickle dex test as well as you have electrophoresis, with which you can find out all these things. So this is not a common thing which we see, so it may be slightly difficult, but you have to remember all these points for referencing. Can you identify what is being shown here? And size of cigars.
Various boxes.
Elastography.
Let's check the causes of such presentation. So this is various pictures. These are normal thromboelastographs. This is the anticoagulant. The initiation of the clotting is taking a longer time. So patient may be on anticoagulants, or there may be a hemophiliac patient. So the reaction time and play time are prolonged. MA angle, the amplitude and angle are decreased. This is the case where platelet blockers are there, that is antiplatelet agents. The reaction time again is also normal, but the play time is prolonged and the amplitude of the clot is decreased. This is fibrinolysis, where instead of being a normal like this, it is getting thinned out. So it is a tail appearance, which is fibrinolysis. Hypercoagulation, the whole thing looks, the reaction time is very short, onset of clotting is very fast, and the thickness of the clot is also very much increased. And BAC happens in two stages. Initial stage will be hypercoagulable, later stage will be hypocoagulable to a prolongation of the clot formation. So, the point of care testing done to assess coagulation. It can be BTCT, activated clotting time, thromboelastogram, rotum, or the point of care stage. How TEG differs from rotum? The difference between thromboelastogram and rotational thromboelastometry is the short form. This is the main difference between the two. So in thromboelastography, which one rotates? It is the oscillating cup or rotating cup. The pin is stopped in the static position. The torsion wire with the pin, they are all static. Whereas the cup which holds the blood, that rotates. Whereas in the thromboelastometry, the rotum, the pin rotates. This is the oscillating pin, whereas the cup is static. Okay, that is the main difference between that. And the graph that is produced is slightly different between these two, and the names are also little different. Common question examination nowadays. This is another shape. What is this called? This is another one to assess the coagulation profile or the clotting ability. This is called chronoplot. The working principle. That's an electromechanical transducer, tubular probe vibrating. There is the whole blood incubate, that strands are formed. The whole thing is displayed as graph would be like this, not like the regular graph that we get in the sonoplot signature. They call it as sonoplot signature. So find signals appearing. So this is a clock signal. is depicted in AMP is one is the previous normal and other. Can you identify this condition?
Exophthalmosis.
No.
Exophthalmosis.
Ophthalmos. See, look at them. Whenever you see an eye like this, what should you immediately look?
Thyroid glands.
Graves'
Goiter.
disease. Goiter. So, what clinical examination you want to perform is examine thyroid gland swelling. What investigations are needed to confirm your diagnosis? Must do. What will you do? Supposing it is a Graves' disease, what test do you want to do? What investigation you want to do?
Thyroid and
T3,
antibodies
T4
or
receptor.
antibodies.
No, what is this? Really surprised. Thyroid hormone profile. See, when you suspect hyperthyroidism, you want to know the values, how to treat that condition. I'm not giving the answers. I wanted how to answer this. How do you treat a hyperthyroid patient? What is the antidote for that? What drug do you use?
Propylthiouracil,
Carbon with
carbimazole.
antithyroid.
Obsolete. No, carbamazole. Is the drug which you use. What indicates? This is the problem in just giving a routine topic and asking you to prepare and then come and answer all the questions that are asked. Suddenly, if you are given a condition like this, some of the other topics you have to develop the skill of immediately recollecting whatever you studied and then trying to answer that question. That is what is very, very important.
But these things, sir, but these things they have to know, no, sir. Anyway, they need to know, sir.
Other than that, that short time they have to produce that answer. No, that is what I am saying. That the skill they have to develop quickly thinking. It's like answering a quiz program. You don't have time. Otherwise, the question will pass on to the next person, and ultimately the quiz master only will get the maximum points. That's what happening today. Okay. Now, after patient surgery of thyroid excision, initially you give all the medical treatment, it fails, and ultimately you go for excision of the thyroid. Patient is having difficulty in breathing. Examination of the vocal cord is like this. How do you identify what is happening here? What has happened like this? Thyroid surgery, total or subtotal thyroidectomy has been done. Patient is having difficulty in breathing, and you put a laryngoscope and you see here. This is the picture you are seeing. Left arm?
Recurrent laryngeal nerve palsy.
How do you say to left? Why not it be right? Which one do you think?
The adductor.
Adductors, partial or complete?
Partial.
Is there any intra-op monitor to prevent this problem?
Some special tube.
Madam is giving you a proof.
EMG can.
Alex.
EMG tube can be used to
yes, you can use that. Okay. Well, what is this coaching use? You are seeing it every day in your stations. What do you call this sort of pictures that are appearing? You know the answer. They are called scalars. Okay. This is the scalar seen in the ventilator. What mode of ventilation is this? The pressure, flow, volume. So patient trigger, flow cycle, pressure limited mode. Okay. Patient trigger. You can see the triggering before the respiratory effort. Okay. This is the flow which shows both inspiration and expiration. Flow cycle, pressure limited mode. And we call pressure support ventilation also. So the clue here, set PS level. When pressure support you are setting. what are the indications for this mode with use during weaning from mechanical ventilation without disconnecting the patient from ventilator. For the earlier mode of weaning, before this sort of facility came in the ventilators, what was the routine method we used to adopt for weaning a patient from ventilator? Totally disconnecting him from the ventilator, but at the same time trying to prevent hypoxia, using a circuit which is used mainly for pediatrics. If I give all the clues, at least you see whether you are able to answer. Patients were disconnected from ventilator but remain intubated and allowed to breathe spontaneously through a TP support. That was the older method of weaning. And if the patient becomes hypoxic, indicated by tachycardia, sweating, restlessness, then immediately we used to reconnect him to the ventilator and then go for mechanical ventilation. Then again after 4 hours, 6 hours, again do what is called the trial weaning. All these things were done. But nowadays, all that hazard is not there once you put the patient on this type of ventilation. So you can gradually reduce the support and straight away extubate them without disconnection from them. So what is failed extubation? Hello? I'll close the I see it taping. I don't think many slides are there. I'll close. Okay. So failed extubation is if the patient is re-intubated and connected back to mechanical ventilation in 24 hours, it is called a failed extubation. So I think you have another class to learn. So shall I close here for benefit of all of you? There are another 40 slides are there.
Yes, sir.
Right. So I will stop sharing. So I think today's class is going to be a little disappointing for all of you. The majority of you are finding it a little difficult, but don't take it seriously. Try to take it as a stimulation to read more and try to answer the questions faster so that you will be able to complete your papers in the examination. Okay. So I have asked some of the unusual questions also, just to stimulate the thinking, like the newer CO2 absorbers, all those things are available in the newer books. So I have included them. But the routine basic things like neuromuscular transmission, lateral sodium, malignant hyperkalemia, thyroid, all these things you should be able to answer. Okay? So it's only a question of connecting your theory knowledge and trying to recall them and answer your questions much faster in the examination. Okay? That is the purpose of this. So if you have any problem,
I think actually we should do more of such Osce questions, sir.
yeah,
Because
I got about
that's what
Emma, anytime I already have 10 question papers ready, prepared for some other batch last year before the exam. And
so we'll do one thing, sir. So we'll do along with the theory. We will do every class. We will do 5 Osce questions.
yeah, என்னோட paper வந்து அந்த அதே patternலயே I have 25 Osce questions which can be rapidly got through with one long question and one long case is there. So அந்த மாதிரி வேணா வச்சுக்கலாம். You can tell them the long
Yes, sir. Okay. We'll give it to individuals. Yes.
Finish it within 15 to 20 minutes and then go for this Osce type of questions.
Yes, sir.
That will be better. Yeah. So thank you very much.
Yes, sir.
Thank you, sir.
Thank you, sir. Thank you, sir. Thank you, Professor, for being schedule. And I thank all the students also. And next week, continue with the office session, sir.
Yeah, continue with the Osce, but I will give the case scenario beforehand so that anyone student can prepare that and present it.
Okay, sir. Any particular case, sir?
No, I will let you know because I have prepared an Osce with different case scenarios. Almost 9-10 question papers are there with me. check that one particular case scenario, they can present that, then we can provide. Okay.
Okay, sir. Okay, sir. Thank you, sir. Thank you so much on behalf of Raisa. I thank our beloved professors, and I appreciate the participation of our participants, PG students. And I wish you all the best in your future career also, because of the knowledge we have shared here is going to transform into safety and well-being of our patients. And it is going to be the future of our fraternity also. Thank you once again all. With all your permission, I will sign off this meeting. Thank you, sir.